Thank you very much. So we'll start with, because Pluristem is a public company, I'm going to ask you to memorize this, and while you're doing that, I will tell you, I'll give you the answer to a question I get commonly, and that is Pluristem is an American company. We're actually incorporated in Nevada. However, I'm the only American in this American company. The other 100 people or so are in Haifa, Israel. So let's talk about Pluristem for a little bit, and then I'm going to go into some of the bone marrow indications that we're working on. Pluristem is, as I said, a public company. We're on NASDAQ under the symbol PSTI. We're also traded under the symbol PLTR on the Tel Aviv exchange as well. And we use, our product is called placental expanded cells, or PLX cells for short. And we believe the common denominator, or the sweet spot for these cells, is the inflammatory ischemic state. We believe Pluristem is actually has a monopoly on the industrial expansion of adherent stromal cells. No matter where those cells come from, they can come from bone marrow, fat, placenta, et cetera. And we believe the 3D culturing technology that we have enables us to manufacture specific PLX cell products for specific indications. So instead of having a one cell for everything, we're going to be able to manufacture specific products. And we can do this because of our three-dimensional expansion technology. In addition, the three-dimensional technology enables us in a very efficient system. So it enables us to produce cells with extremely high margins. In addition, we have several data points now to suggest that we can give our cells into skeletal muscle and get a systemic effect from these cells in a paracrine type of mechanism of action. As I mentioned, we have the rest of our employees are in Haifa, Israel, where the technology came from. It came from a co-collaboration between the Weizmann Institute and Technion, which we've purchased those patents, by the way. So here's our life cycle, and we're currently working with women that have had cesarean sections, and that's really more convenience than anything else. We can be present when mom has her scheduled surgical procedure, and then screen the placenta, and if we don't like it, we basically throw it away, which is what would have happened to it anyway. We then take the mesenchymal stromal cells from the parenchyma of the placenta and then seed our three-dimensional bioreactors. Approximately 7 weeks later, we have cells that are ready for harvesting that can be cryopreserved, and then hopefully treat the millions of patients that are going to need cell therapy without any matching necessary between the patient and the product. We don't intend to market and sell our products. We are hoping that especially pharma and large pharma will be doing that for us. And we have already announced our first collaboration with United Therapeutics, who licensed our cells for the indication of pulmonary hypertension about a year ago or so. So as you probably know, the industry norm is to grow cells in a two-dimensional Petri dish, flat surface type of technology. Bone marrow or adipose tissue is the primary source of those cells. On the bottom, you see that we get our cells from the placenta. We seed polystyrene carriers or wafers, which you see in the middle there. And it's kind of like growing cells on the rungs of a jungle gym and then stacking the jungle gyms one on top of another so that these cells will grow in this three-dimensional spatial characteristic. And then we put these wafers in a bioreactor, and which again is a very efficient system. So the PLX cells that come out of that three-dimensional expansion technology, the surface markers are essentially what you would see with the typical MSC. As far as immunogenicity is concerned, we have intermediate expression of HLA class 1 and negative expression of HLA class 2 on these cells, as well as a negative expression for CD80, CD86, and CD40. As far as differentiation is concerned, the cells essentially do not differentiate. We believe that we inject the cells. Again, we are using the intramuscular route of administration. So we believe the cells begin to die pretty much as soon as we inject them, and you really can't find them after about 8-9 days. So why grow cells in a three-dimensional expansion type technology? And there's several very distinct advantages for doing this. One is product consistency and quality. Remember, this is a totally self-contained piece of apparatus which we can very precisely control. In addition, there's huge efficiencies, as I mentioned, in the production of these cells. We can manufacture cells at roughly 5 to 10% of the cost of growing an equivalent number of cells in a Petri dish. As far as the number of doses we can get from one placenta, we're actually building out our new laboratory facility, our new manufacturing facility, so that, call it first quarter of 2013, we'll be able to start manufacturing commercial grade cells in commercial quantities, and at a dose of 300 million cells, which is what we're using in our vascular trials. We're going to be able to manufacture approximately 10,000 doses from one placenta. But probably the coolest advantage of growing cells in a three-dimensional environment is this ability to manufacture specific PLX cell products. We don't monkey with the cell. We're just farmers in that regard, but we do precisely control the environment in which the cell grows in, and so that we can actually change the secretome on a permanent basis, so the cells can then be produced, specific cell products can be produced for each indication. We have 1 year confirmed stability shelf life at this point. We've invented a thawing device which takes just a couple of minutes for the cells to thaw in this thawing device. By the way, the cells are going to be supplied to clinical sites and later commercially in vials. And then the administration is with a standard needle. It's simply like a flu shot injection, IM injection. So as I mentioned, the effect of the cells is more paracrine. We believe that the inflammatory ischemic tissue responds by sending signals to our cells, which have been deposited as a repository into skeletal muscle, and then our cells respond by secreting a cocktail of anti-inflammatory, cytoprotective, and angiogenic proteins. And also, as I mentioned, we now have several data points to suggest that we can give the cells intramuscularly and get a systemic effect. Not only the angiogenic effects of the cells, but also their cytoprotective and anti-inflammatory effects. And we believe that this is actually a pretty big deal. We believe it's easier for the patient, certainly safer. The cells remain in the muscle. They don't go anywhere. They don't differentiate. They do tend to survive longer, can be given in higher doses, and have a heightened secretion of proteins when they're given in this mode of administration. So again, if the common denominator for the use of these cells is the inflammatory ischemic state, that obviously covers a lot of indications. And this graph just points out to you some of the indications that we've been working on. The top one is in vascular disease, specifically peripheral vascular disease, and that's where we're in. We're in clinical trials right now. We're just started a phase 2 trial in intermittent claudication, and we've completed a phase 1/2 trial in critical limb ischemia. But we're also working in the area of ischemic heart failure, ischemic heart disease, diastolic heart failure, orthopedic injuries, as well as pulmonary diseases primarily. Those are all great, but I want to spend hopefully the rest of the time talking about the bone marrow recovery indication that we have. And the story about how this all began actually begins with our relationships with several countries, including Israel, the United States, and Germany, where these countries are looking for a product that can be stored in a central location that would be a mitigator for acute radiation syndrome, the hematopoietic component of that syndrome. So in working with these people, we had done quite a bit of animal studies at the Hadassah University Medical Center, where we would irradiate animals and give them sublethal doses of radiation, and then give our cells, initially intravenously, but then later, I mean, with the idea that if a person needs to access this central repository of product for treatment of, God forbid, a dirty bomb or whatever, probably the best way for the patient to get the product is to give it to themselves. That's when we began to think about using the cells intramuscularly. And when we did, in these experiments, the IM route of administration actually worked better than IV. So we were giving animals sublethal doses of radiation and then waiting at specific periods of time and trying to figure out how long we can wait and still rescue the animal's bone marrow. So as you can see here, the survival of the animals, and this is just one example, this is just one experiment, and you can see that the sooner we give the cells after we've irradiated the animal, the better off we are in terms of survival. Still not bad. You can still wait 48 hours, and it looks like there's still a good response in terms of survival of the animals versus not giving our cells at all. If you look at the bone marrow of these animals after 23 days, you can see that there's a significant response in terms of the return of the nucleated red cells of the bone marrow, and also in terms of the hematological progenitors that the bone marrow contains during the PLX cell therapy versus controls. And if you look at the hematological lineages, really it doesn't really matter where, when you give the cells, they're all quite a bit better in terms of response for red cells, white cells, and platelets versus the vehicle controls. So there's quite a few cytokines, chemokines, and growth factors that are elaborated by these cells. But we also believe that our PLX cells will influence the secretion of other cells as well. And here's an example where we see that PLX cells induces the IL-10 secretion by LPS-activated peripheral blood mononuclear cells. We've also done work where we have irradiated animals and then used CD34 positive cells either with or without our PLX cells. And you can see that if you use our PLX cells in conjunction with these CD34 positive cells, then there's a huge increase in the engraftment of these cells when our PLX cells are used. So this all gave us the idea of potentially using the cells in aplastic anemia. As you know, in aplastic anemia, bone marrow stops producing the lineages. The diagnosis actually peaks around age 20 to 25, but then there's another, it's kind of a bimodal peak, and then after age 60, there's a high incidence, and one begins to think about environmental toxins and whatnot that causes aplastic anemia. Certainly quite a bit higher incidence in Japan than the rest of the world. Here's the bone marrow of a patient with aplastic anemia. The bone marrow on the right is compared to normal. You can see the significant hypocellularity of the marrow. And of course, the blood lineages, all the blood lineages are affected, white cells, red cells, and platelets. So patients with aplastic anemia have a sequela of fatigue, recurrent infections, of course bleeding, and the treatments protocols include transfusions, growth factors, immunosuppressive agents, because people really think this is a immunosuppressive treated problem. And of course, bone marrow transplant therapy, which is actually increasing. The trend is to do a bone marrow transplant earlier rather than later. The 5-year survival rate for patients receiving immunosuppression is approximately 75%. So if you look at the pathophysiology of aplastic anemia, you see that certainly I guess the most favorable hypothesis is this is an autoimmune reaction, and with the suppression of hematopoiesis mediated by the expansion of cytotoxic T lymphocytes. And certainly at Pluristem, our in vitro models suggest that PLX cells reduce T cell proliferation in response to mitogenic stimulation. In addition, there's a transient immunosuppression that the cells demonstrated in our phase 1/2 trials, which also may be playing a role in terms of mitigating this disease. In addition, CTLs produce inhibitory cytokines such as TNF-alpha or interferon gamma, which can suppress progenitor cell growth. And again, we have evidence to suggest that our cells reduce both TNF-alpha as well as interferon gamma. And And then lastly, Tregs are significantly reduced, and the infusion actually of Treg cells ameliorates the progression of aplastic anemia. And our in vivo animal models suggest that we have a Treg cell increase with our cells. If one thinks that there might be a change in the bone marrow environment that's correlated with aplastic anemia, certainly they see levels of VEGF in bone marrow as well as in serum that's significantly lower in patients with aplastic anemia, as well as a reduced angiogenesis and microvessel density. And suffice to say that our cells do secrete a variety of angiogenic cytokines, including VEGF. So that leads us to the treatment of this little girl. What happened was we were doing all these animal studies at the Thawing University Medical Center, and there was this six-year-old girl from Romania with aplastic anemia that had failed her first bone marrow transplant. In fact, we believe she also had graft-versus-host disease and had a severe colitis. In fact, they were thinking about doing a total colectomy on the patient if she were to be stabilized. So approximately 5 months after her first bone marrow transplant failed, they gave her a second bone marrow transplant, and her attending physician, who happens to be the head of the transplant unit at Hadass, saw that she was actually failing this transplant as well, and decided at that point, because he knew about our animal trials, to petition the state of Israel to give this little girl our cells, which happened. She got 2 doses, 2 courses of therapy, approximately 80 million cells because she was fairly thin and emaciated. She got them 2 courses 5 days apart. And then subsequently, approximately 10 to 12 days post-second course of PLX therapy, her blood lineages began to rise, and to make a long story short, the patient was able to be discharged. Her colitis, by the way, entirely went away. It was totally normal. So she's now thriving back in Romania, and this is her last blood count, which was back in latter August, which you can see the blood count is normal. So we actually think that there are several potential hematological indications for the use of our cells, including hematopoietic stem cell transplant failure, or the enhancement of the engraftment of the hematopoietic stem cells, like, for example, with cord blood, of course, acute radiation sickness, as well as chemotherapy-induced bone marrow hypoplasia, starting to eat into the markets where you see Neupogen and Neulasta and Epigen being used. So I think that is us. That's the management team. I appreciate your time. Thank you very much.
Thank you. Well, it's a great story about the little girl. Any questions? So my question will be actually, so you have an allogeneic therapy, right? Derived from placenta, you mentioned you can derive from 10,000 doses per production run, so per placenta, correct? I'm sorry, what was it? It was 10,000 doses per placenta you can manufacture.
Right, at a dose of 300 million cells, it's 10,000 doses.
So you don't have a master cell bank like other allogeneic.
No cell bank.
What I'm wondering is if you know how regulators, for example, will see testing of each production run, because basically every placenta represents its own kind of product. So do you have an idea around that?
Yeah, and I mean, I think that's part of the advantages of growing cells in a three-dimensional culture, because we are experts at that. We can control the batch-to-batch consistency. In fact, we have written documentation from regulators on both sides of the ocean that our batch-to-batch assay to measure batch-to-batch consistency, which is endothelial cell proliferation, is quite adequate. Yes?
Yeah, hi, that was a great talk.
Thanks.
I'm curious, oh sorry, I'm calling Elaine from the Fred Hutch. I'm curious if you can tell me a little bit more about how much you've interrogated donor persistence, and you see this nice effect with, I guess, in this transplant, the second donor cells are the ones that are contributing to hematopoiesis. Have you guys continued to look for evidence of these donor cells that you've given her?
You're correct. The HSC that was stimulated in the little girl, and we've actually had 3 patients now that have been treated with our cells. But in this situation, we've identified the HSC to be from her second bone marrow transplant that was stimulated, if you will.
And then in your preclinical models, have you again, look for persistence of these donor cells, or have these mostly been xenograft models, or have you done mirroring?
I can't answer that. It's probably over my head.
Okay, thank you. We have a question over here.
What about the allogenic cord blood usage?
We've documented that we can, we believe that we can increase the engraftment of the HSCs contained in cord blood with the co-administration of our PLX cells. That's what we've documented in animals. But we don't otherwise deal. In fact, we did that very early on. We did it a few years ago and proved that, kind of put it on the back burner because as a company, we wanted to have a standalone product initially and not have to use our cells with somebody else's product like a cord blood, and we had no control over a cord blood bank at that time, and still don't have control.
Thank you.
Are there any other questions? No, thank you again.